here. Oops. So I'm going to spend the next 15 minutes or so talking about concussion from a clinician's perspective. I'm a neurologist. I'm a sports neurologist, so I take care of athletes on the sidelines. I take care of them in clinics and training rooms, all sort of different environments. We'll talk a little bit about each of those. The first point I wanted to make, actually, Dr. Sleep made for me already, which is that concussion happens not only in football, it happens in other sports. Water polo actually was one of our most popular concussion sports at the University of Michigan 2 seasons ago. Very, very violent sport. People don't realize that. Women get concussed. It's not a male-dominated thing. It's not a football-dominated thing. All sports can have concussions in them. That's a very important point to keep in mind. The other thing is I want to point out that brain injury in sports is not a new concept. This was first described in the medical literature in JAMA in 1928 in boxers. A review by Dr. Martland looking at 23 individuals, boxers, mainly in England. He described them as having a constellation of symptoms that had to do with cognitive problems, slurring their speech, balance issues, and he coined the term punch drunk, or being slug nutty, which I think is another wonderful term. So this is something that's been in our, we've known about it, but we thought it was mainly a boxing issue. In 1969, somebody else wrote about it and looked at the prevalence of this diagnosis in professional boxers, and estimated about 17% of them would have some type of cognitive, long-lasting effects from boxing. Now, this is boxing. This is where professional boxing, where the point is to concuss somebody. So this is sort of the higher end of the dose spectrum, if you will. The term dementia pugilistica was also coined at about that same time. But up until this point, our own sports, our contact sports, hadn't been really entered into the conversation. We were pretty much thinking this was just a boxing-only phenomena. But things change over time. How we play our sports change. Certainly our helmets kind of reflect the change over time. And of course, the NCAA itself was founded in 1906 by President Roosevelt, trying to protect athletes, football players mainly, who were dying playing football from head injuries. So it's something that's been in the conversation for a long, long time. But only recently have we begun to look at our sports, and it started with football, looking at athletes who have, retired athletes who had that same kind of punch-drunk type presentation. They had mood issues, they had cognitive issues. Mike Webster there on the far left committed suicide. I mean, these are things that have started to come into our popular media culture, especially with books like Head Games here and Play Hard, Die Young. These are two very popular books that help get this idea of problems from repetitive hits out into the public. Now, with that, of course, all sorts of media folks started getting on the bandwagon. The New York Times has been sort of our primary medical journal on concussion, if you will, over the past 5 years. And this article, which says dementia risk seen in players in NFL study, kind of started what I really consider the whole recent phenomena of attention to this injury. Now, this article actually describes an Institute of Social Research study done here at the University of Michigan, which looked at the health of retired NFL players and compared that health to those of population averages in a survey that they have put together and have given for many, many years, a health and retirement survey. Asks about 100 questions. Everything from, do you go to church? How many friends do you have? Do you drink? Are you depressed? Do you have pain medications that you use? And one of the questions was, do you have a diagnosis of Alzheimer's, another dementing illness, or some memory complaint from a physician? Yes or no? And so, first off, the people asking this question identify themselves as being from the NFL, and you're asking ex-NFL players if you have a problem. Second, you're asking somebody who might be demented to answer the question. You're not asking for any kind of backup of the information or the diagnosis. And third, as a neurologist, if somebody comes to my clinic and says, I have a hard time remembering things, the three things I look for and explain 95, 98% of all those cases: sleep, mood, and pain medication use. Those three things are threefold higher in NFL players. In the same survey, those answers were there, but that part got lost. The other thing that I will say about this survey, and I've told Alan Schwartz, the person who wrote this article, this very fact. If you look at it, They also ask the question, do you have a diagnosis of cancer from your doctor? Which is not as easy to, it's not a vague answer, it's yes or no cancer. And it's threefold in ex-NFL players, despite the fact that they smoke a lot less. So where's that? And the reason that isn't out there is because there isn't a narrative to drive that part of it. And this is where the NFL comes into play, and this is where Congress comes into play. And I bring this up only to lay out what I think is a lot of the reason we're having these conversations has to do with non-medical, non-science type driven information. The NFL, of course, has a collective bargaining agreement that they have to sign up for every once in a while. And that is, of course, as you know, not in effect currently. They have a labor issue. But Congress has decided that this is something they want to champion. And this is a great thing to champion, for sure. But how many congressional hearings have there been since the election on concussions? Maybe a couple here or there. Before, they were falling out of trees. And the picture in the bottom right here is from a congressional hearing that John Conyers had in Detroit. And this picture, I think summarizes my point on this topic, and then I'll move on to actual concussion science here in a sec. This is Kyle Turley, played for St. Louis Rams, New Orleans Saints, defensive lineman, known for his physical play. And that's Chris Nowinski, who wrote the book Head Games, ex-Harvard football player and professional wrestler. These guys are great patient advocates. They really have done a lot for this injury. But they're the ones that the New York Times takes pictures of. They're the ones that get, in the paper. This right here, if you can see this, that's my shoulder. And Coach, you might recognize Dan Hendrickson right there, right? There's Dan. It's a team physician from the University of Michigan. So science is pushed to the outside in the background of this topic. But the problem isn't really, in my mind, and probably in your mind too, it's not the NFL players. I mean, obviously, these are guys that have picked a vocation that's risky, and they understand that. And there are problems there, of course. I don't want to minimize those. But the real problem is that the number that Dr. Sleek gave us, 3.8 million concussions a year, if I can put that in some kind of visual perspective, it's like if you took the big house on a Saturday and you multiply it by 30. Number of concussions per year in the United States from playing sports. So the problem is our youth athletes. The problem is the high school kids, the junior high kids. These are the ones that we need to figure out what they're at risk of. And we don't know. We really don't know that answer at all. So what is concussion? Let me turn to that for a sec. So here you have a brain. Remember, a brain is floating in a skull. You have spinal fluid that kind of keeps it floating in there. And concussion happens, as Dr. Sleet said, when the brain moves quickly. You don't have to have a hit to the head. As long as the brain is moving fast inside of the skull, it can be a direct force going this way. It can be a rotational force. But essentially, that disrupts function. Concussion is not a structural injury. There's not bleeding. There's not a bruise. It is an injury of the neurons not talking to each other like they should. In essence, you end up kind of like Homer Simpson on the bottom here. That's sort of the simple version. But there are two important steps, I'll break it down, that I think are really important clinically for a physician to realize when they are looking at athletes as patients. So, of course, here's some of the symptoms, and Dr. Sleet had a much longer list, of course, but I want to make one point. The loss of consciousness in concussion is actually pretty rare. About 7% of concussions involve loss of consciousness. It used to be thought that you had to lose consciousness to be concussed. That's not the case at all. But the point I want to make is twofold. So neurons are a collection of, they're cells, and they're arranged in networks talking to each other, right? So inside your brain right now, hopefully you have networks that are paying attention and listening and for, understanding what I'm saying. I have different parts of my brain that are working. Athletes, depending on what you're doing, different parts are working. And when the force is applied to those neurons and they can't function, it's not that there's a part of your brain that's bruised. It's that the network is messed up. You can't get the information around like you should. Now, the point I want to make, though, is that every brain is different. And if you just apply the same amount of force to everybody in this room, I'm not going to get everybody concussed. And everybody's going to have a different concussion presentation. The second point is that just because you're having dysfunction doesn't mean you're producing symptoms, right? That's something that I think gets lost in this conversation. And it's, for me, one of the scary parts about this injury. From other parts of neurology, from seizures, from strokes, from MS, you name it, you can have clinically silent versions of that pathology. So why should we expect that everybody who's concussed has this injury, this dysfunction of the neurons, has to be producing symptoms, right? So that's the second step, is producing Homer Simpson. The first is producing the dysfunction, but then that brain has to be able to produce the symptoms of concussion. So to me, there are two areas that introduce sort of genetic variability, introduce the concept that not everybody's alike. There's an injury threshold. Like I said, will your brain start down this path? And will your brain produce the symptoms? And there are tons of things in my mind that I look for to help frame that risk. History of migraine headache, history of other headache disorders, mood disorders, learning disabilities, psychological makeup, all sorts of things can help or hurt in either one of these two thresholds. So a couple of quick facts about concussion beyond that. First, as I mentioned, each concussion is different. There's a feeling in medicine in general that we want to be evidence-based. We want to have classification systems. We want to have 1 + 2 = 3, X and Y, this and that. Concussion doesn't work that way. It's not an ACL injury. It's not a shoulder separation. It's not even an MI. It's much more complicated than that. And to have that knowledge that is a much more variable injury is the only way we can move forward in trying to find treatments for it. Most concussions do resolve after about 7 to 10 days in adults, but about 10% don't. And they might last 2, 3, 4 weeks. I think in the case of the basketball player in the video, that kind of crosses over into post-concussion syndrome, which is maybe a separate diagnosis, so that's a little bit of a different thing I'm talking about. But why do they last, so long in somebody and not so long in somebody else? It's a dynamic injury. It's not something that you sprained your ankle and it's done. It's as if you sprained your ankle and kept running on it and didn't take care of it and didn't splint it. Once you're injured, if you continue to use your brain cognitively or if you continue to exert yourself physically, you can make that injury worse. So how you handle yourself over 7, 10 days will help define how long that injury lasts. And then the risk of playing on. What of all those youth kids, the high school kids who are playing sports, they get concussed, what is the real risk of them if they continue to play? The biggest risk is their injury is going to be a lot more complicated, like the woman in the video. Instead of a 7-day concussion, it's going to be a 7-week concussion. Instead of a 2-week, it's going to be 6 months. That's the number one risk. A smaller risk would be of a catastrophic injury that's very, very rare and something that we all want to avoid for sure. But I can guarantee you that if you are concussed and you're continuing to play, you're going to have a worse injury than if you rested and did what you're supposed to do. So 2 cases I want to talk about real quick just to highlight some of these points. The first, these are both from my clinic last week. I could probably take an average week and just throw cases up here, and they're interesting stories. This is a high school player from a small town in Michigan. He is a junior. He's a very dominant offensive tackle for his team. He's very large and in shape. Therefore, as most people who know football know, he plays defense as well and special teams. He does everything. So he's playing every single play. He's a 4.0 student, no history of concussions or no other medical history that makes any red flags pop up. He's in a game, second to last game of the year, and this team is running an off-tackle play. He's telling me, he's like, we're dominating this team running this off-tackle. And they just run it and run it and run it. It's like Wisconsin last year, second half, right? They just ran it, ran it. So every play, he's engaging this kid, and he's dominating this kid. But he's kind of enjoying the physical. I'm going to just hit him. So 16-play drive, 5-6 yards at a time, whatever. Touchdown, turnover. They get it back, another 40 yards or so, same play. He ran it, he said, like 19 times, 20 times in about 25 minutes of bang, 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 over and over and over again. He started getting a headache. He started feeling like he didn't know what was going on. He didn't have the one big hit. He had no hit that you would say that would be on SportsCenter that would say, oh my gosh, look at that hit. He was doing his job over and over again, and he started feeling off. Then later in the game, he was covering the punt coverage and took a hit to the side of the head, and then couldn't get up, a little wobbly, nauseated, really confused, bad headache, went to his coach. Coach said, you're fine, just sit down and go back in the game later. So he goes back in and plays and just getting worse and worse. After the game, they won by like 40 points. He's crying, he's despondent, he's yelling. He doesn't know why he's yelling. He's yelling because he's crying because he's yelling. He's just this spiral of emotional problems. And his coaches are like, okay, well, let's get back on the bus. And they're 2 hours from home. So he's driving home, and his 16-year-old friend on the team calls his parents and says, I think you better pick him up because, he's not acting himself. So here's a situation where the coaches had a great opportunity if they knew what they were looking for. And it took his 16-year-old friend to say, okay, well, something's wrong. So they pick him up, take him home. That weekend goes as you would expect. He's in bed, sleeping. He's not doing anything. He can't work out. He's feeling miserable. He goes to see his athletic trainer on Monday, who says, well, let's go up to a city nearby and go see somebody. And they did that, and they did the impact test. Impact is one of these computerized neurocognitive tests you may have heard of. If in the news you read something about Tim Tebow needing to pass his concussion test, that's what this is, this impact test. It was administered. He didn't have a baseline version of it. They just did it. He had normal scores for his age, and they said, okay, well, if your headache gets a little better, you can play. And his next game was on Thursday, 3 days later, and he was cleared to play, despite the fact that he still had a bad headache and couldn't go to school and focus on his classes and couldn't really walk straight. But he passed his impact test. Why? Because he's a 4.0 student, and if he had done the baseline test that you're supposed to, they would have known that he was actually not doing very well. So in this game, basically every possession he's getting worse, he's getting worse, he's getting worse. Again, they're dominating this team, and they're up 45-3 or something, and the team scores a touchdown, the other team. And he's on extra point coverage, and he wants to block this extra point. He said, I don't know what got into me, but I wanted to block this like nothing I ever wanted to do in my life, even though they're up by 40 points. He was losing rational thought. His frontal lobes were kind of disconnecting a little bit. And he went after that ball. He said he blocked this kid. He hit this kid harder than any kid he's ever hit in his life. He couldn't get up. He couldn't get off the field. He laid there conscious, too dizzy to get up, started vomiting in the field, and 5 months later, I see him in clinic last week, he still has headaches. He can't stay in class and concentrate. His grades are starting to slip. So to me, this case sort of illustrates all the things that go wrong or can go wrong. And education obviously would have been a big part of this, of his coaches, of his parents, of the person who gave him the impact test. I mean, there's a lot of points in that system, and if somebody would have been educated about it, this kid probably would be doing a lot better. The second case is a high school soccer player, and this is a better story. She has a history of migraine headaches, right, which is important, I think. She had, before she came to me, 4 total concussions. She had 3, 1 in 2006 and then 2 in 2010. All similar. This is actually her. Somebody took a picture of her about to have her 3rd concussion. She's number 20 in blue. She shared this picture with me, and I said, you got to be kidding me. That's actually you about to get concussed. So all 3 of these concussions happen the same way. She's going up to head a ball, head-to-head contact, and she has head pain, nausea, photophobia, sensitivity to light, that kind of thing. But she rests. She comes out of the game. Each time her symptoms last 3 or 4 days or so, maybe a week. The second one was about a week. And then she sees me for the 4th concussion, which was last week. And again, 3 or 4 days of symptoms, and she's fine. Each time she rested like she was supposed to. But she also has a history of migraine headache, which puts these concussions in a different light to me than the first case. So for me, 4 concussions in this patient, I'm not as concerned. Again, because her brain is wired to produce symptoms. I know that from her history. So the fact that she's concussed from hitting her head against somebody else's head is not surprising. So for her, she's going to go to college and play soccer. So we're going to do some very thorough baseline testing. We're going to do full neuropsychological testing. We're not going to do a computerized version. We're going to do an MRI looking at particular connectivity within the brain. 2 different cases, 2 different outcomes. The last thing I'll mention real quick, so I mentioned concussions so far. I haven't talked about this chronic traumatic encephalopathy thing, the thing that everybody's worried about at the beginning. So concussions is that clinical syndrome from getting hit. This is sort of a long-term dementing illness, which is probably, I think, really irrelevant of whether you were diagnosed with a concussion or not. It's more about dose of contact over a lifetime. In this diagnosis, the brain does change. Here's some tau deposition, tau proteins, much like you see in Alzheimer's disease. The pattern of deposition is different in this diagnosis than Alzheimer's, so that's why we think that's what this is. But we don't know that this is impact related. Nobody's been able to do the animal study that shows this is putting these 2 things together. It's all assumed at this point. And for me, that's one of the big questions we have to figure out. What is the actual risk that we're putting our athletes at, our youth athletes, our high school, college, professional athletes? I can tell you one way to look at it. This is Reggie Fleming. Reggie the Ruffian Fleming was his nickname. He was a very physical player. Played for St. Louis and the Rangers. He was the first hockey player to be diagnosed with CTE. He diagnosed in 2009. He had his brain riddled with this tau deposition all over. And he had a very typical Alzheimer's course, but much faster earlier in life. Bob Probert, who many of you in this room probably know, also had a diagnosis of CTE at autopsy. He died of heart failure at age 44. And he had a whole lifetime of problems with mood issues and addiction issues. Was that a cause or an effect? We don't know, but he did not die, or nor did he have, to my report, somebody told me who knows him, he didn't have any neurological manifestations when he died, but yet he was given this diagnosis at autopsy because his brain looked the same way. And the third person I'll mention is Red Berenson. Red came up to me recently after Reggie died. Reggie and Red were teammates for St. Louis, and Reggie died, and I saw Red. I gave a lecture to the coaches a year and a half ago. And he says, Doc, you know, I think why him and why not me? You know, I played the same way. He wore a helmet, true, Red did. But here's Red at age 70, 71, signing a 3-year contract and leading our team to the Frozen Four on Thursday, versus his friend who died, neurologically devastated. So I said, Coach, that's why I need your brain when you die. He said, okay, Doc, you got it. I was like, all right. So for every Reggie Fleming, there are thousands and thousands of Red Berensons, and we need to figure out what makes these people special, so that we can counsel them to maybe avoid contact. One last thing in prevention, I'll wrap up real quick. Preventing concussion, I think, comes down to 4 things mainly. It's technique. We need to tackle more and hit less. Coach, I hope that makes sense. So right, technique, don't hit with your head. Play by the rules for sure, and we have to continue to have our leagues, college, professional, youth, whatever level it is, really enforce the rules as they're written. Proper equipment is good. There's not a concussion-proof helmet. Helmets do not prevent concussions because that's not what they're designed to do, nor do I suspect they ever will. But wearing a new helmet that is certified is definitely a thing to do. And overall, consider how many impacts you're taking, not only in a practice or a game or a season, but over a lifetime. I have a high school, for example, patient 2 weeks ago came in, plays football and hockey. He plays football for his high school, hockey for his club team, then transitions into rugby and soccer in the off season. So all year round, he's getting hit. You know, I calculated maybe 8,000 hits a year he takes. To prevent complications, it comes down to the 4 R's that I like to say. Recognize concussion when it happens, report it when it happens, remove that player, and let him recover. That's really the essence of it. I'll skip that slide since we're out of time. And then, Coach, this last one's for you. Go get him, right?
Yeah.